Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Our topic for today is osteoporosis, how to diagnose it and how to manage it with Dr. Lani Simpson. Osteoporosis literally means porous bones, and it refers to a condition in which the bones become fragile and the risk of fracture is increased. According to the National Osteoporosis Foundation, 1 out of 2 women and 1 out of 4 men over the age of 50 will break a bone due to osteoporosis. And what's actually worse, I think, and that's actually, I think, an older statistic, so it's probably worse now. The most common sites of fracture are the hip, the spine, and the wrist. If you have osteoporosis and you break your hip, there's up to a 40% chance that you'll die within the next year. When you look at a bone density scan, if there's a T-score of minus 2.5 or worse, this is generally defined as osteoporosis, and a T-score of 1 to minus 2.4 is termed osteopenia, which is a loss of bone, though not as severe as osteoporosis. As I understand it, the way we should understand osteoporosis is that throughout our lives, we have a balance of both cells that build new bone, osteoblasts, and cells that clear out old junky bone, osteoclasts. When we're younger, there's a tendency for the osteoblasts to dominate over the osteoclasts. And when we get older, there's a tendency for the osteoclasts to dominate over the osteoblasts. Dr. Lani Simpson is a doctor of chiropractic who has established herself as an expert in bone health and women's health over the last 35 years. She's a certified clinical densitometrist, which means she's an expert at reading bone density tests. And she was the first alternative doctor, meaning non-MD, to be awarded this certification. She produced the Down to the Bone course for practitioners, and she's been presenting the Heat is On, menopause, and PMS seminars for chiropractors, acupuncturists, and other practitioners for the last 35 years. She's the co-founder of the East Bay Menopause and PMS Center and of the East Bay Osteoporosis Diagnostic Center. Most importantly for us, Dr. Simpson is the most knowledgeable doctor I know about bone health and osteoporosis. Dr. Simpson, thank you so much for joining us.
Well, thank you for having me. I always enjoy talking about bones with you.
So let's pick some bones. Let's start right in with how do we test and diagnose our bone health, and when should such testing occur?
Okay, so a lot of times what's happened in the alternative world is someone will come in a doctor's office with a bone density test. And what they have is the report. And that's in the 90s, the first bone density machine came on board. In fact, I had one in 1994, 1995. So you didn't hear as much about osteoporosis until then. Prior to that, there was some ways to test bone density, but it wasn't good. But at that time, also, there wasn't any way to treat it. The nursing homes were full of people who had broken hips, mostly women. The 1/4 of all hip fractures also occur in men. And men, by the way, don't come back from that as well as women do. But when we hear that statistic that you said about 40% don't make it, after they do get a hip fracture, that's probably much older people. So if we really looked at what the age range is, if somebody's 60 or 70 in pretty good health fractures their hip, they'll probably do okay. But those that aren't, they're doing the horrible diets, they're not not eating well. I mean, you and I know about that. We
That's the
talk about all
typical
that.
American.
Yeah, so we are seeing more osteoporosis, and I really, really am concerned for the 30 somethings. I mean, my kid is like 32 or 30, no, 33. And I'm concerned about that generation. They've been the kids that were on computers, not exercising, not getting impact. My kid rides a bike, but that's not impact. And the food. A lot of young people don't cook anymore. I mean, this is true across the board, but with each generation, we see certain things that are just plain bone depleting habits, and they're not good. So obviously preventing osteoporosis is one thing, but it's quite another once you've been diagnosed. Can you reverse it? And frankly, I just have to say to everybody, if somebody says you can reverse osteoporosis, just take my supplements, run the other way. Who are we talking about? Some people have very advanced osteoporosis, but when people hear osteoporosis, they just think, oh, it's osteoporosis. They'll treat it however, an alternative doctor might, here's a supplement. Or the knee jerk for a medical doctor, here's Fosamax. Is it even the right medication? Is it the right sequence to give somebody Fosamax before, say, an anabolic that actually builds bone? So we really have to understand, who are we talking about? My bones aren't your bones, so to lump everybody together makes no sense. And then I have a couple other pet peeves, because you asked like when should somebody get a bone density? Well, you look at someone like me, I'm thin. That's just who I am. And I weigh 115 pounds wet. I'm 5'5". So thin people are more at risk. Now, mind you, I've been an athlete all my life, so that's been helpful to me. But you want to get a bone density on women who are at risk before menopause. And who's at risk? Then women, people who have a background of smoking, alcohol, doing that now. I mean, there's so many things that impact the health of our bones. It's mind spinning. People who are too flexible can have EDS, Ehlers-Danlos syndrome. A lot of the people that we watch, like if we go to Cirque du Soleil or whatever, they're doing great things, but there's a condition there that they have. So there's a lot.
Wait a minute. So being more flexible means you're at higher risk for fracture?
No. Thank you for asking.
They're less at risk.
I'm talking, no. They're if they have a condition where they're hypermobile, so they can take their thumb and put it on their, can you do that? Can you take your thumb and put it on your arm?
Of course not. No.
Exactly. They can do that.
No, I know that.
You put their arm up and it's like,
Absolutely. Yeah, I'm familiar with that condition. It also leads to a lot of gut problems.
Yes, that's exactly right. So it makes you wonder how much is which, I've had Marfan's folks, patients over the years. It's kind of interesting. There's a lot of ways to think about how I assess bone, but in Marfan's, these are really tall people and they have a long femur neck. They're more at risk because they have a longer femur neck because it's more of a lever. So I always look at how long, because in Caucasians, sometimes we have a longer femur neck. Whereas you look at Asians, though they get it too, but it's more compact. And also shorter people have less distance to fall. I mean, there's a lot of ways I just think about things that make sense about what's the fracture risk. And honestly, Ben, that's what we should be talking about. What is a person's fracture risk? The bone density is not everything. And you and I were talking before we went on about a test called the trabecular bone score. And that gives us a sense. So you got bone density. You want to have dense bones, right? Like a piece of oak, wood versus pine. So oak is really strong wood. It's dense. Pine, not so much. But also that you want whatever you have in terms of bone to also be resilient. So I've had people who have osteoporosis. I have osteoporosis. But my trabecular bone score is good, which is why I haven't fractured yet. And I'm going to be 75 next month. So I haven't fractured. And I'd like to say to you, oh, it's because I've done everything perfectly. No, I think I lucked out genetically because I did a lot of bad things. So genetically, I think I came into this world with pretty good bone quality genetics. We can test that kind of stuff now. But but also I kind of can get a sense about that when someone says to me, I've been an athlete all my life. I have never broken a bone, but I just got this diagnosis of osteoporosis. If they've broken a major bone, that for me is time to do serious workup. Like if they've broken their humerus or their femur or their wrist. And then also I want to know what happened to that fracture. Okay, you fell over. Like I had this one woman who was on a tennis court and she fell backward on both hands. So she kind of equaled that weight, right? 52 years old, shattered both wrists. That's not normal. Well, it turned out that, yes, she had osteoporosis, but she was also going through menopause. So that probably tipped things over a bit because number one cause of osteoporosis is estrogen loss. That is primary osteoporosis, which is why it drives me nuts that women, especially who are at risk, are not given a bone density prior to menopause. Because by the time they're 60, they come to me and now they have full-blown osteoporosis with fractures. So I know I kind of went off in a couple directions there. Maybe you can bring me back.
Okay, so let's get back. Let's put a little detail on the picture. Let's go into a little bit about the DEXA scan, and then also maybe explain a little more exactly what a trabecular bone score is. So a DEXA scan reports on the hip and the spine and sometimes the forearm as well. And it's giving a rating of the density of the bone in the T-score as compared to a younger person, and with the Z-score as compared to somebody equivalent age?
Yeah, so we're measured up against the database is average 30-year-old. And we actually want to do that because some people say, oh, I don't want to be measured up against them. I want to be measured up against my own age. No, you don't. You kind of want to be close to a 30-year-old average 30-year-old. The further you move away from that age group, because that's when by the time we're 30, I mean, peak bone mass, the bulk of it is done by the time we're 18. So 80% of our peak bone mass that we were destined to potentially lay down, and hopefully we did nutrition well and exercise during those years, is laid down at that time. And by the time we're 30, we don't have all that help of the extra hormones. We just don't. So that would be the time, and if people understood that, to increase their weight training. We know weight training works in terms of stabilizing bone and in terms of, sarcopenia, resisting that as we're aging, because the people who have the worst osteoporosis as they age are people who have muscle wasting and osteoporosis. But the one thing I want to say is that one bone density test, and this is really critical, does not mean active loss is occurring. So you can have osteoporosis diagnosis, but maybe that happened, and I like to use this word so people think about it, historically. So we know eating disorders, for instance, a lot of things like that. But also, maybe there was a period of time you decided to be a vegan. And when people do an extreme diet, and vegan is one of them, some of them have the worst bones I have seen. I'm not saying they can't be vegan and have good bones, but I am saying when I hear the word vegan, it's a risk factor, big one for me. So any kind of big change that's going to eliminate food, those are, and frankly, a lot of people who had eating disorders go into these diets, the intermittent diet. Okay, I mean, we can do some of it, but
vegans tend to perk up when they hear about somebody with a fracture and right away say, well, that's because you eat meat. That's why you had a
And that's
fracture.
nonsense. Absolute utter nonsense. I don't eat meat. I don't eat anything with 4 legs. I do eat chicken. I eat turkey. I eat fish. And I wish I could do dairy, but I can't for other reasons. So the protein thing is so critical. You can take all the calcium and vitamin D and vitamin K and all that kind of stuff. If you don't have enough protein, and I see that over and over and over again in my patients, and most of them are women. Okay. I got men too, but protein is critical. You can't build bone if you don't have good protein.
But of course, the vegan argument is all animal protein is acidic, and that's
Acidic.
going to leach calcium out of your bones to produce more to balance out your pH.
But here's the interesting thing about that is that there's always a kernel of truth. Yes, if somebody is on a strict paleo diet and they're just slugging down a lot of meat, yes, it's acidic. So I'm talking about a little more of a balanced approach that, and not missing the forest for the trees. I talk about this a lot. We also saw for many years, and still going on, doctors recommending 10,000 a day of vitamin D. Have they tested the vitamin D? Have they tested the serum calcium? Have they tested the parathyroid? You can't do that. That's a hormone. And for some people, especially those who have primary hyperparathyroidism, that is not a good thing. And also some people are sensitive to high levels of vitamin D. And my second book is on, a lot of it is around vitamin D, is that some people, even if they're at like 40 nanograms per milliliter or 50, I'd say 50 nanograms per milliliter, my sweet spot's about 45. I don't care how much vitamin D you take. I want to see the blood level. And you have to respect it this way. You have to test.
We test all the time. And
Yeah.
in Southern California, and I'm amazed at how many patients in Southern California who regularly go out in the sun still have low vitamin D.
Yeah. Well, Australia's the same thing. We were talking about that the other day. So people are told to stay out of the sun from 10 to 4. You can't make vitamin D unless the sun's pretty much directly overhead. So if the sun is at an angle from time of day or season, you don't make vitamin D. And then you've got people slathering on sunscreen. And here's the thing, I support that to some degree. And the reason I wrote my second book is because I've had 25 rounds of skin cancer. And 3 months after that book came out, the vitamin D book, and sun book rather, with a lot about vitamin D, I found my first melanoma. It was like a freckle that had darkened. But I'd had so many skin cancers because why? Because I abused the sun. I had so many sunburns as a kid, horrific sunburns. And you've got some doctors out there saying, oh, no, you don't get it from, of course you do. If you abuse anything, that's not good. So, however, I don't always put my face. I don't need any more sun on my face, but I will expose my skin for 5 minutes here, 5 minutes there, but I take vitamin D. So vitamin D is very important, as you know. It increases absorption of calcium, magnesium, phosphorus, and it does so many other things in the body. But the problem is that absurd study that came out, and I'm sure you're probably aware of it a couple years ago, that was not about vitamin D, but they went in and looked at some vitamin D stuff. And they said, vitamin D doesn't do anything for osteoporosis, doesn't reduce fracture. And then they said, oh, and by the way, don't test. I was so upset about that because it's wrong. I don't care. See, sometimes studies come out, they can be large. This was a epidemiological large retrospective study. What does that mean? So people don't know how to read studies. It meant nothing because all you have to do is understand basic physiology. That what does vitamin D do? It increases calcium, magnesium, phosphorus, all of which we need for our bone. So of course it helps bone be strong. Of course. See, studies, I can kind of just tell by hearing about it if it makes any sense to me physiologically, right? So, and since we're on calcium, let me just say this. I like to kind of get rid of these stupid ideas that are out there. When you hear a generalized statement that is supposed to be for everybody, like, get all your calcium from food, I could scream. Who do they get this on? Who are those people? They're average Americans who are eating pizza, who are obese, they're not me, for God's sakes. I'm not going to eat as much. I don't eat as much food as a lot of people. It is harder for me to get the calories I need in, and certainly calcium. And I don't eat dairy. So and then plus, and let me just throw in the vegan thing again. Vegans who eat a lot of greens, a lot of oxalates. We see more kidney stones now because, you've got to have calcium actually to make sure the oxalates are going to go out in the stool rather than go into the kidneys. So I got off track there.
So
I was okay. So here's the point.
Point out a couple of important things about getting.
Wait. Let me finish that one thought, Ben. So the main thing is really be careful about generalized statements because it doesn't apply to everyone. And when I'm dealing with osteoporosis, most of those people are taking maybe 600 a day of calcium citrate, citrate malate in divided doses. And some are taking as much as 4,000. Why? Because they had part of their colon removed or whatever. Or their intestines removed. So it's really, and now we have more and more people who are getting gastric bypass. Their bones are in bad shape. All right. I just get my soapbox going here.
Yeah, no, any sort of gastrointestinal condition, the majority of them are going to decrease the ability to absorb nutrients. Even a simple condition like small intestinal bacterial overgrowth means you've got too many bacteria lining your small intestine where the bulk of absorption of nutrients takes place.
Yep, exactly. Digestion's key.
So let's go over some of the important things about a DEXA scan and why some places, some DEXA scan centers get it wrong in terms of the things that need to be done, like, for example, the positioning of the patient.
Well, another pet peeve that I had hoped over the years I'd have some influence on, but I haven't. And I'm still going to work on that as I'm moving into retirement because it's just outrageous. It's not required that anyone be trained who writes the report or signs their name to the report of the bone density, and the technicians don't have to be trained. So we see errors. People send me their bone densities. I find errors almost on every one of them, one way or another, but I'm really picky. And those errors, like say, for instance, let's say you had a perfect bone density test. They did it right. And then the following year, the person was sloppy and they didn't rotate your hip properly. That can be a 7% gain or loss. And if it's a loss, that's going to trigger a medical doctor to give you a medication.
So let's describe the position. The patient's on their back.
Yeah.
Do they have something under their knees?
That's the best way, but are they doing that? No.
Okay.
And in my book, by the way,
that would flatten the spine.
Well, it would be better to have the knees up so that it's down. Right. But now, let's say the first time you had a bone density, your legs were straight. So then you're getting smarter and you decide you're going to go in and say, you know what? Make my back flat. No, you don't want to do that because it's going
to compare to another.
You're right. Now, in my clinic,
you're supposed to be rotated in 15 degrees.
Right? That's right. They put you in a little thing. So the GE Lunar equipment typically have both legs out at the same time. And pretty much Hologic's doing the same thing. It's faster. So is it the best way? No. When you have the back flat, you're going to get, as you know, you're not going to have any overlapping. You're going to, it's just going to be better, to analyze.
And if the patients have scoliosis, that's going to affect the results.
If a patient has scoliosis, I had a case in the other day. Woman had 45-degree scoliosis. This center, and it was it was Mayo or one of the big places, did the bone density of her spine every year. And she had a lot of rotation. When you have rotation, okay, so when you have rotation, or if you let's say you're well, I can't really see if this comes apart. Okay. So when they're doing a bone density, it's straight through, right? P to A. And when there's scoliosis with rotation, now what do you get? You get some of the transverse processes and so forth. You're going to get a false reading. It's going to show a better bone density than it is. Now, if you have two vertebrae that don't have rotation or very, very little, that you can't use one vertebra in the spine for diagnosis. You can use two, you can use three, and better four, so that, we can look at all four. So the spine is typically going to be lower than the femur. That's the discordance. For people who have arthritis, it's going to falsely elevate the density. So I always, by the way, and this is me, I always order the forearm because it gives me additional data to look at. Like there's only one diagnostic place in the mid forearm. It's the mid forearm. That's compact bone. So the spine is mostly trabecular bone. And what's good about what we call the ultradistal radius is that it's mostly trabecular bone. So it gives me another area to kind of get a sense about trabecular bone. And I like that. So the more, like I say, I have these data points, the better.
If the patients have osteoarthritis,
that's going to falsely elevate. Or like I had a case where the person had spondylolisthesis, a forward slippage of L4 onto L5. Well, L4 was all messed up. And they should see, if they were trained, they would delete L4 and then only include L1 through 3. So in the bone course that, you and I have talked about, that I'm starting on April 20th, I'm going into detail about how to look at bone densities, because all doctors who are entertaining helping people with their bones should get the full bone density, not just the report. You want the images. So you either want to get the CD or ask the center to print out the images from the computer. You don't want them to go into a file and make a copy of it, because it's going to look like blobs. If you get my book, y'all, and it's still good, look in the back. They look like sharp little x-rays. And I can glean a lot from that information.
If a patient gets a conventional x-ray, not a bone densitometer, and that shows bone loss, what does that mean?
Well, first of all, it doesn't show bone loss. So it's better just to, what it does, it shows density. So again, remembering for everybody, a single bone density doesn't mean there's active loss. Right. We're after that question to answer. But on an x-ray, if an x-ray says osteopenia, it's actually osteoporosis. Because the word osteopenia means low bone density. That's all that it means. But in order to see that on an x-ray, you have to have about 40%, note how I'm saying this, less bone density in that spine for that to be real. So that would mean that it would be, from a T-score perspective, about a negative 3.5 or negative 4. So each standard deviation is 12%. So if I have a negative 4, it's like 48%. And a lot of times, yes, that is visible on an x-ray. They can see it, and they can see it in MRI. But what the report will say, it won't say osteoporosis. It'll say osteopenia, because that's how they do it in radiology. But don't expect a radiologist actually to still write a good report. I'm just saying.
I've seen where they write slight bone demineralization.
That's a good term too. So when they're seeing that, that person has osteoporosis. And it's low bone density.
Okay.
And we have to think about it, mostly what we're looking at, especially in the spine, you're losing that nice lattice infrastructure. So you can imagine if you lose that, how are you going to build that back up? You're going to take some supplement to start growing these, see, you have to think, you have to kind of think this through and understand bone. But I also say that we can build bone quality at any time. And I have seen people like you, Ben, who can increase bone density with the right program. It happens. It's just not as common. And
So-
let's say I did bone turnover markers on you, and or someone, not you, because you really work out and all that. But I do bone turnover markers, and I can see that bone turnover is high. That should not be happening. That means bone loss is occurring. And here's the interesting thing. So my top two bone turnover markers are the teleopeptide, that's CTX, and the P1NP, which is the procollagen type 1. So the CTX is a peptide, and it gives us information about osteoclastic activity.
So these are
Bone turnover.
tests that can tell us about whether or not the person is losing or gaining
Actively.
bone. Yeah.
Actively losing.
Right.
It could be stable. So let's say that CTX comes in at 700. Okay, now that's giving me a hint. Notice the words I'm using, everyone. A hint that active bone loss is occurring. But I had to order 2 bone turnover markers at least. And now the P1NP, which is a marker of osteoblastic activity, is high. So you would think that would be good. It's not. So in this case, let's say the CTX was 750, P1NP was 120. They are turning over bone and losing. I want to see the P1NP around 30. I want to see the CTX around 200, or 250. Then I think they're pretty stable. But if those are high, they are losing. The P1NP should only be high in one case, and that's if somebody's on an anabolic medication. Now, the other thing I'm doing, because again, I'm doing this course that's coming up, is I'm reviewing all the data on people like you who work out a lot and bone turnover markers, because you may be the exception. But that said, even people who work out and do all the right things, because I have people say this to me, they come into me, they have a bone density, they've got osteoporosis, they just fractured something, they were walking across their lawn and fell on their hip and fractured it. I can't have osteoporosis. I've been doing blah, 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 No, you can't. So a lot of different things, a lot of prongs in this wheel of bone that have to be illuminated. But it's very individual, which is why I don't think this is ever really going to be handled that way. But you and I both know when you evaluate somebody, it's an individual.
So let's go over some of the other tests. Osteocalcin, and then Genova offers an uncarboxylated osteocalcin.
Now, the undercarboxylated is kind of a no. So where this all comes from is Kate, I think her last name starts with an R, a vitamin K book. And I've interviewed her myself many times. She's super smart, but I don't think it's really holding up. But here's what we do know from a physiological perspective. Vitamin K2 does stimulate osteocalcin. Osteocalcin stimulates osteoblasts. To what degree is it going to help? I've never seen any evidence that that alone as a treatment would work. I wish I could.
Now, could that be because very few people are taking the proper form and the proper amount of vitamin K?
Okay, so we got K2, we got MK4 and MK7. The proper would be the MK4.
Correct.
If we were really looking at it.
Dosage.
Well, wait a minute.
45 milligrams, which.
And that's a hell of a lot. So you better hope that that's right. So that was first on the scene, Japanese studies, and it was actually used as a treatment for osteoporosis.
Correct.
I'm just saying, it's weak as a treatment program. It's not, it didn't pan out, So what about MK7? So MK7 comes along in lower doses, milligrams, take maybe 120 micrograms versus the 45 milligrams, because as Dr. R, again, do you know her name? I can't remember her name.
Who are you thinking about?
The woman who wrote the vitamin K book. Kate, anyway. So, and that's where it really got launched, the MK7.
Right.
So, and that we find, of course, in foods. We find it in, we find MK4 in foods, but it's going to be more animal sources. MK4 is in animal sources, like, dairy and meats and so forth. So, and by the way, our large intestines, if they're healthy, actually make some MK4. So MK7 comes from fermented foods. And the reason that kind of took off, and that book was kind of written, and why she thought vitamin K, MK7 was better, it has a longer tail, so it lasts longer in the blood. MK4 you would have to take throughout the day so that it would be available throughout the day. I'm looking into this again, Ben, because I want it to be true, but I'm pretty critical now. And it was interesting because a couple of weeks ago in my doctor's group, there was a woman who, I can't think of her name right now. She's a researcher on nutrition. I thought, oh, great, here we go again. Because the typical people, the doctors in my group are phenomenal. I mean, I see them save lives every day. They bring the most complex cases I get to learn from. Nutrition? It's ridiculous. In fact, one person came a few months ago to give a little nutrition thing. You can eat peanut butter and white bread, and you'll still get enough protein. I'm screaming, But I learned a long time ago, they don't know nutrition. And I don't bother with that part because I get to learn all the other stuff from them in terms of diagnosis and so forth. But the foundation of every treatment program should include obvious, digestion, nutrition, all that stuff. So, but anyway, this woman came on and I was kind of blown away. She was a real critical thinking researcher on nutrition. And, I asked her about the vitamin K. I said, I'm just not seeing that much in terms of real solid evidence. But here's the thing. Do I think people should get vitamin K? Yes. I don't even do MK4. I just don't think I think it's fine if you do it. I don't think necessarily it's hurting. I don't know how much good it's really doing.
But weren't there more studies on MK4 than there were on MK?
Yeah, early on. Yeah. That's true. And I'm in the process of looking at all that again with a little more critical eye once again.
If you look at the different organs in the body, for the most part, vitamin K is stored as MK4. In most of the organs, the liver is the exception where it tends to store it as MK7. But you ingest K1 and the body converts it and stores it as MK4.
Well, not all of it. I mean, it's a smaller percentage than you would think, but yes, it does do that. So, like I said, I'm kind of in the process of going through those studies again. I mean, because I've been at this for 35 years or so, and my ability to kind of look at things changes as I learn more and I develop a wider lens with how I'm looking at things. So I don't know. I mean, I just have to look at it again because, I'm not so sure.
Okay.
But I
So,
will say, wait, I do have one little tip.
yeah.
She also did a study on blueberries, which was really fascinating, where they did like what would be equivalent maybe to 3/4 of a cup of blueberries. I can't remember how they used it. It was powder, blah blah blah, and then a larger amount of blueberries, and then really high blueberry content. With these with animal studies, and they found in this study, which was really surprising to her, that the middle amount actually was supporting the bone turnover markers in a better way than the high or the low. And it whether or not that turns out to be really true with further studies. I mean, we know the polyphenols and, all that kind of stuff and how powerful they are. But can you see people get like really wound up and then they'll do like 5 cups of blueberries, and kind of miss the point, or they'll do prunes. And a prune, I've never bought into the whole prune thing, but to this level I do, which is if people want to eat 4 or 5 prunes a day for bone health, fine. I don't recommend 10 or 12 prunes, which was in those studies. But I do believe that the polyphenols and the boron that is in prunes is helpful.
Trabecular bone score. What is that exactly looking at? Is that measuring the trabecular bone versus the cancellous bone?
It's measuring, yeah. So, well, that's the same thing. Trabecular and cancellous is the same.
Oh, okay.
You
Trabecular
got trabecular and compact. You just, yeah.
compact. Okay.
So, the trabecular bone score, first of all, the bone density is volumetric, centimeters squared in terms of how they do that. And then the trabecular bone score is looking at structure. And structure is what the resilience. Okay, so that's how what we're looking at is that resilience. And I have a video that's on YouTube that I interviewed Dr. Didier Hans. You can just look me up, bone quality. And he really explains it because it's an hour, when we're talking about it. But understanding how important that bone quality is to our bone health. And that's why we can have some people with a -5, meaning 65% of their bone density is gone and they're not fracturing. Is that true for most people? No. We always have these extremes people like to point to, right? But I'm telling you, I've seen it and it blows my mind. So that it just tells you that bone quality is really important. So when you have to get a trabecular bone score, it is separate software that the company has, or the imaging center has to have purchased for about 10 grand. So because no doctors know about it or don't know what to think about it, no one's asking for it. So they're not putting it in because they're not going to be able to recoup their money. You have to have a bone density test of the spine, and then they apply the trabecular bone score. They just push a button to run the trabecular bone score test. And then you get a nice little printout, and the higher, the better. So 1.4 something is really, really good. So let's say I have somebody with normal bone density, but that trabecular bone score comes in as like a 1.080. That's not good. And that person often will come to me because they've already had a fracture that didn't make sense. So it's really important, this bone quality. And of course, again, there's genetics involved there, but also what else would affect bone quality? All the things you and I know and do with patients: nutrition, gastrointestinal health. I mean,
Sleep, exercise, on and on.
well, and I have people,
Smoking, drinking,
over exercising. We've had people with what we call now, and there's an article on my website called anorexia athletica. So there are people out there
Sure.
that exercise to all, like running I know this one woman, she runs a marathon a month, very, very thin. I'm trying to get to her. a little bit because, I'm around her some and I've given her my book and so forth. I'm sure she's going to be in deep doo-doo when she gets to menopause. She's right there now. And if she doesn't do something, she's going to start fracturing. And she already has had stress fractures. So are stress fractures a clue? They certainly can, but they can be, or risk fracture can be the first kind of heads up. There may be something wrong with these bones.
Yeah, in general, running marathons, triathlons is increasing your risk of having risk of osteoporosis or fracture.
Well, Keith McCormick is a good example of that. He's a chiropractor. He's written a book on osteoporosis, super smart guy. And when I met him, I wrote about him in my book, my first book. He had 14 fractures.
Wow.
He's the 100 marathon guy.
Oh, wow.
So he ended up doing Forteo, which is an anabolic, and saving his life, I believe. And he still is out there doing that kind of stuff. I do think, that's my opinion. Again, the 100 marathon thing, it's got to be so tough on the body. So one day I said to him, after he got better and stopped fracturing, thanks to Forteo, I said, so Keith, what are you doing now for exercise? And he said, I just did the Tough Mudder. I said, you did what? You know what the Tough Mudder is?
Yeah, I think
it's that really intense. It's a really intense athletic event.
Right.
Throwing yourself over here and over there, you're sloughing through the mud. I said, what did you do that for? He said, I wanted to see if I broke a bone. We all think differently about things, right? That's his thing. So.
Right. Well, that's better than I run into some patients who have osteoporosis, who've had fracture, and now they won't do anything where they could ever fall or have to balance or anything. And that's not the right approach either, because you need to work on your balance. You need to put yourself in situations where you can be safe, where you work on improving your ability to balance and load and things like that.
Yeah, I always say, and it's so true, walk in the world with awareness. But what's happening in the example you just gave, they're so fearful.
Right.
And it's really, I've had to work, I have a background of mindfulness practice, sitting for 3 months in silence in India and so forth. And, I'm out there doing pickleball and doing my sports and stuff like that. I fell a few weeks ago. But I think the fear is worse than the fracture. And the other thing I say to people, fractures are part of life. They just are. They can happen. And, we want to avoid them. And obviously, then most fractures occur because people fall, pure and simple.
Right. So exercise for bone health. It looks like from the studies I've been reading about that the most effective exercises are involving heavy weight training exercises, things where you load the bones.
Yes.
Like doing squats, deadlifts, and it looks like there's some special benefit to doing, if you can do it in a safe way, some high impact ballistic exercises. I'm sure you're familiar with the Lip Moore trial from Australia.
Yeah, Belinda Beck.
Where they have people jump onto a pull-up bar and then drop down.
Well, and here's the thing. When they first came out, I went up against them because they were showing people with rounded backs doing just as really bad. But I'm a former Iyengar yoga teacher, so I'm very big on the mechanics of the body. But even something like OsteoStrong, which I did a whole video on that, I'm very against that program, and it's ridiculous and dangerous for a lot of people. He said, you can't fracture. Of course you can. If you sit there and strain and you have severe osteoporosis, and you know this, if you increase your intrathecal pressure, you can then, we think different about Schmorl's nodes as we get older. You can end up with the Schmorl's node, which is what? A fracture, fresh one.
Right. But I think the reason why they feel that it's safe is you don't sit there and suddenly get a big load on you. It's based on how much you're pushing or
You're
pulling.
straining.
And so you don't start out with the heaviest load.
No, but it's BS, period. Their claims are wrong. He got his PhD in Cayman Islands. I mean, I could go on about this guy. You don't want to support him in any way. I did an hour-long, he's with, Anthony Robbins. I did an hour-long video on him. It's over on YouTube. I have 65,000 views on that, making no money on it. But I just got so tired of these people. And they make these claims. Oh, you just have to do it 10 minutes, 20 minutes, once or twice a week. It doesn't happen. They claim 14% increase in 6 months. It does not happen.
Well, they're claiming that you have to load your body weight. You have to put a load of more than your body weight. I forgot if it's 2 or 4 times your body weight to really cause new bone formation.
They have like 150 studies. I don't know. Have you watched that video I did of them?
No, I haven't.
I was warned by the Canadian group.
I interviewed John Jaquish before, though.
Yeah, John. Yeah, I know John.
Yeah.
I said to John, I said, bring me over 5 cases early on, because of course he would like me to support him. He shows them to me. He doesn't even know how to look at bone densities. I said, well, first of all, John, this one you're showing me, you're comparing the right femur to the left. And then this one, I said, oh, this person's 80 years old. They have osteoarthritis, John. I mean, none of them were correct.
Okay.
So and I was warned not to put that up because they would come after me. None of their attorneys. Do you think they would if I was wrong? Yeah. And then there's another one that Laura, can't think of her last name, out of Canada, who's one of the top exercise experts in the world. She put up one about them as well, because we're all tired of hearing about them.
What about vibration platforms?
Well, the original big hoo-ha came from Clinton Rubin. And I was, back in the day, when I was involved in all this, people gave me stuff. I've got the Juvent, I've got the Meradyne, because they wanted me to sell things. I sell nothing, I never have, but I would support something if I thought it worked. So what do I think? So when you stand on a Juvent or you stand on the Meradyne, and all this stuff about NASA, see, this is where people have to start putting their thinking caps on. NASA, did the studies on what machine? And did they continue to use it? The answer to that's no. And it didn't work. And it was done on the one and only machine was the Juvent. And the Juvent, I have to say, which goes for around 6,000 or 7,000, is a very solid piece of machinery. And it feels like a hum when you stand on it. So who would I maybe recommend this to? I would recommend it to people who can't exercise, because it has a 0.05 vertical displacement. So the idea is by doing that, hundreds of times, in a short period of time, your body's going to think you're jogging. I would do it with people who have had lower limb, fractures, people who just can't exercise. That's who I go for. Forearms, they can lean on it, and they have to be able to afford it. But I would not recommend it for you. I wouldn't recommend it for me. I can exercise. Now, what about the more intense power?
I've been using one for the last several months.
Yeah, well, you may have another reason to do that, and that could make sense. So, but the power plate, which is more intense, and I've used one of those, and I have to say, absolutely, I feel my balance was crazy good after that. But it's so violent, and I'm concerned with retinal detachment, which definitely has been, that's a big concern. And also, a lot of these vibration machines don't have vertical displacement. They have horizontal. And in horizontal, we don't, in the world, we don't have horizontal vibration. And so I'm concerned about the health of the joints with that kind of thing. So you have to be really careful if you're getting into that stuff. And do we really all need now to buy vibration equipment?
Okay. Best diet for preventing fracture or increasing bone density?
Balanced one. And, in my book, I talk about it, although I'd up the protein now. But yeah, it's about having that balance between it. Really, when I say to people, here's the diet you should do, dump the junk. Do you not know what the junk is? If they're at that level and they're still drinking, a 6-pack of Coke a day, I don't know how far you're going to get with them. But people know what junk food is. We had a vegan restaurant, not a restaurant, but store around the corner from us. And it was just a bunch of junk food. So you want to eat, 3 good meals a day. I always eat a really, really good breakfast every day. I have protein, I've got, eggs, I might have a piece of turkey bacon with that or two. I might add some hemp seed. Actually, I like to do a tablespoon of hemp hearts and a tablespoon of pumpkin seeds in the morning. Right there, I've added about 8 grams of protein.
Yeah.
And I do avocado because I want to have the fat. So I do all that. I just can't eat as much as you, Ben.
I do have a big breakfast. So I think this morning I had a container of egg whites with chopped up kale, onions, mushrooms. I had avocado and I think and chicken sausage in there.
Oh, that's my favorite because I like to put together, mushrooms, kale, and onion. It's like kind of my go-to.
Yeah. So what about including soys? There's isoflavones in soy, and some studies have shown some benefit with those.
I mean, like genistein and
Diazine, and then there's one called ipraflavone that some people are selling.
Well, ipraflavone is it's not from soy. It's actually just chemically made.
Okay.
And the question is, and I talked about all this in my book, would I take it? No, I don't think there's enough evidence. I think there's evidence for eating a really good solid diet. You have to get enough calcium, get enough vitamin D, magnesium, B12. I mean, you kind of
is
everything.
Dairy a good idea?
What's that?
Dairy?
If I could, dairy is, it is true that dairy is inflammatory, but then you hear people say, if you eat dairy, you're going to lose bone. That is just so asinine. I'm sorry. It just is. I cringe when I hear this kind of ridiculous global statement. And then you got people like every few months you hear the same, kind of thing go out there. Or like get all your calcium from food. Like that's going to work for everybody. You got to be really careful about buying into these things.
What do you think of? So let's go into nutritional supplements now. We talked a little bit about calcium, and you said maybe on the average 500 to 800 milligrams a day.
Depending. It really, again, it's very individual. And where they're, I always want to look at their comprehensive metabolic panel, get a sense, especially if they had 3 or 4 of those, because then you can really kind of look at the total protein and the calcium over time. But I like to see, again, it's about blood level for me. So I like to see it around 9.3, 9.5 would be really nice. But when you're on the low end of normal, it's not good. When you're on the high end of normal, it's not good. So I talk about when I'm teaching lab tests to note when you're looking at high end and low end normals. B12 is another one. We used to think
Let me stop you on the calcium. Serum calcium is probably not a great measure of the body's need for calcium, though, isn't that right?
Wait, say that again.
Serum calcium, in my estimation, I don't think is a particularly good marker for the body, the amount of calcium the body really needs. I don't think it indicates tissue levels.
It's the best we've got. Gives us an idea. I mean, that goes along with, by the way, if I'm evaluating somebody, I'm going to be doing a 24-hour urine. The interesting thing about a 24-hour urine, high into normal, low into normal matters also. So when you do a 24-hour urine for calcium, let's say it's low or on the low end of normal, they're not getting enough calcium, at least on that day. I'm going to do another. I always redo tests. I'm going to do another one. But there's also a whole way, I can't explain it in this thing, but you got to do it right, and I'll test it again. When somebody, and this is a really important point, when somebody comes to me, I'm not taking new patients now, but when my older patients come back, and I'll still work with them. I never change anything. You want to do lab work first. So I think a lot of doctors of any persuasion immediately want to start messing with stuff when they don't even know what they're dealing with. Are they actively losing? What did the CTX say? Because then, if you have that groundwork done, then you'll be able to see if whatever you do is helping. If the person, if it's a woman, her CTX is 600, 700, she's year 2 of menopause. You might help her a little bit with nutrition, but boy, puts low dose estrogen in there, get it up to 50 in the blood. It's going to bring that down to usually about 250. I'm not a big fan, by the way, of gels and all that kind of stuff. So that's a whole other topic. But all these things matter.
What do you think about Algae Cal?
Oh God, that's another company. Don't support them. They make claims you're going to gain blah, blah, blah in 6 months. Of course you're going to gain because you're going to be doing strontium. And strontium does what?
Improves absorption of calcium.
No, it replaces calcium. And now in the bone, and now because of where it is on the periodic table, is going to show a higher bone density that's not real.
So you don't think there's any benefit to strontium citrate?
No studies on that one. Strontium ranolate's where the studies are. Now, is it worth doing if somebody cannot do anabolic medications, they have very serious osteoporosis? I would consider it. I just know the anabolics do a much better job. But to have these people out there willy-nilly just taking strontium, again, when a doctor has not actually evaluated this person fully, is just not right. So, yeah, I don't really like the Algae Cal company. So I'm careful with companies that I recommend or work with. And the other thing too is what is Algae Cal? They call it like, plant calcium. It's calcium carbonate.
I heard
oral calcium is calcium carbonate.
You sure of that?
Yeah.
Okay.
But email me if I'm wrong.
Okay. I tried to check that and I couldn't find any data from the company's website to see if
where does the plant get it from? It absorbs the nutrient. It absorbs it from what? The soil. So, and it's because a lot of times people say, oh, calcium carbonate, it's rocks. Of course it's rocks. But that doesn't mean it's also bad, by the way. There are some people now that I would calcium carbonate, if they really do have an acid problem, calcium carbonate may be the way to go till I get other things going. But overall, citrate's the way to go. Kidneys love citrate.
Magnesium?
And kidneys, yeah, go ahead.
Magnesium?
Glycinate.
Should we be 2-to-1 calcium magnesium?
No, it depends. Some people, can do that much. Others can't. It depends on their digestion. It depends on their sensitivity to magnesium. So it's a bit of a balancing act and understanding their stools and all that kind of stuff.
Yeah. Yeah, we do an RBC magnesium and try to make sure it's above 5.5.
I kind of stopped doing that because I just didn't see that much difference with it. But yeah, I know. And a lot of docs still order that.
Okay. And your target level for optimal vitamin D?
45 nanograms per milliliter. And that can change. Somebody's on medications and so forth, with especially the PTH analogs. But yeah, that's kind of a good number. There's some
little low to me. I've seen data showing that 60 is a good target to decrease breast cancer risk.
I thought so, but no. And there's too many risks, when you do it. When you have too much calcium, too much vitamin D, what is it going to do? What's going to happen to parathyroid? I'm asking you.
Oh, it's going to grab the vitamin D and bring it into the bone. And if you have enough vitamin K, it'll make sure it
No.
soft tissues.
No, it's going to decrease your PTH, parathyroid hormone. So the kidneys and the parathyroid glands and vitamin D kind of all work together. That's in my second book, because we need the parathyroid gland to, if it's too suppressed, you're not going to get what we need from it, which is the osteoclast clean up old bone, right? So when in the body, the parathyroid hormone, that's what it does. Interestingly, the parathyroid analogs for teriparatide, nabaloparatide, and timolol work differently. They build bone, but they also increase osteoclastic activity, especially for Teo. So it's interesting. So there's a lot of complexity with all of this. But the point is, if you look at people in Hawaii who are out all day not wearing sunscreen, their level's about 30. So what you're doing is a big fat experiment right now, bringing people up to 60. Nobody did that. Nobody had 60. Who has 60? And just normal life. So I think that's too high, and you run the risk of losing bone when you get too high for certain individuals.
Yeah, I'm not sure if that level 60 though.
Well, I wrote the book, but you can think what you want. But I'm saying, I think it's better to be a little more cautious. It is a hormone.
45. What about boron?
And then I need to stop. So,
Okay.
Well, this is another good one. I'm glad you brought this up, because boron, I don't even know the name of the guy, but he was like recommending high doses of boron. It was going to do this. And this is what I'm talking about. We see this kind of stuff. Do you know who I'm talking about?
I interviewed Laura Pizzorno, and she has an article, nothing.
Right, the algae cow people. Yeah. Yeah, well, and she has an article, and who cares? So is boron, no, really. So is boron helpful to bone? Is protein helpful to bone? Yeah. But to do high levels, there is no evidence over time that's safe or a good idea. So when you start doing that, and it's really interesting because alternative doctors kind of love to do high doses. So let's do 10,000 vitamin D now. Let's do 20 milligrams of this, that. But that's kind of extreme.
So what do you consider high? What do you consider a safe?
I think if somebody's eating a good diet, eating apples, and things like that, and maybe prunes, and they're getting enough. I've reeled it in. I have to tell you, Ben, I've reeled it in over the years, because I don't know. I've just seen too many things now, and I would rather be in a real safe zone because we really don't know. long-term, or the blueberry example I gave you, somebody ate 2 cups of blueberries a day, is that going to be beneficial, or is it really just kind of like 1 cup, you know?
Let me ask you just one more quick question. Fluoride, is that good or bad for bone?
Well, fluoride is bad. But is it bad if in small amounts, because it's in soil, it's in, kind of everything, and especially now, they use, the waste product fluoride. They're watering everything with that water. I don't think they're filtering the water. So I think,
Of course not.
But the question is, is there a way to really test? So I don't, it's interesting. I just don't. I look at bone density, bone quality. I don't know that I would have associate high fluoride drinking water, with that. My bones are good. I drink a lot of water. I don't know. I mean, but back in the 80s, that was one of the main treatments they were going after, because when they gave people fluoride and they looked at X-rays, the X-rays were like really dense. So they were really excited because it did increase density. But what happened over time was that these people on the fluoride started fracturing. These nice, dense looking bones started fracturing because the quality was terrible. So the thing is I guess as I've gotten older, I worry less, with the more I know, and I just try to keep myself in a good, even keel and do the best I can and get through this life. And I'm careful about articles I read and things that people say, because people just say stuff. They do. They just say shit. I'm sorry. They just do, Ben. They say stuff all the time. And I used to be one of those people, but now I'm a little more, I don't know, maybe a little older and wiser. I'm not sure.
Okay. You are definitely wiser. So tell everybody about where they can find out about your books, and tell us about this upcoming course that you have.
So on April 20th, I'm starting a course, maybe the only time I do it live. And it's 20 hours plus. So I take people through the basics of what you need to know in terms of reading bone density tests. And honestly, this is also for people who may want a different career, or add to their, they may want to get into really helping people. So how I frame my work, and I have for years, is I'm an educator. I don't take insurance, and I charge good money to see me. But I right now, the only thing people can really get online is the bone density second opinions. But it's needed. And I really feel, I've always felt actually, the chiropractors should have their hands in this. But what I keep learning is that they just don't want to. I've been teaching for years. People don't, they didn't really want to mentor. So that's what I'm creating with this. So I've even got some doctors from Peru that have joined the course, which is great. So it starts on April 20th. And it'll start on a Saturday for 4 hours. So I've got it in 4-hour blocks.
And how do they find out about it?
Go to my website. It says Bone Course.
And your website address is what?
Lani, Lani, Simpson, SIMPSON.com.
Great.
And they can find out about my books there, and they're sold other places. They're in libraries, So, yeah.
Excellent. Thank you so much, Lani.
You're welcome, Ben. Very, very nice working with you. And I'm really glad that you're learning about it and helping people the way you do, because it's so important.
Thank you. Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. If you would like to work with me personally to help you improve your health, I do accept a limited number of new patients per month for a functional medicine consultation. Some of the areas I specialize in include helping patients with specific health issues like gut problems, neurodegenerative conditions, autoimmune diseases, cardiometabolic conditions, or for an executive health screen and to help you promote longevity and take a deeper dive into some of those factors that can lead to chronic diseases along the way. Please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we'll set you up for a new consultation for functional medicine. And I look forward to speaking to everybody next week.